Good afternoon, and thank you so much for being with us, Dr. Katy. We're honored, and we could not thank you enough for being a part of SACT and making time for the whole conference. And great talk. You can see from the question answer session how many people uh, enjoyed it, and they're going to take the feedback. Now, coming to the NK cell, how the whole field is. Do you think it's going to be more dominated CAR NK strategies now? There's a shift from CAR T to CAR NK, especially in the hematological space, with very good results coming in. Your paper, very recent paper. So, what do you feel about that?
So let me first start by thanking you. And Albeena, this has been such an incredible visit. And so thank you for your generosity, for inviting me. I'm also very grateful to Dr. Narula and really the whole
Thank you.
agency. This is it's such an honor to be here. The meeting's been fantastic, great lineup of speakers, and I'm really honored to be here. Of course, I'm biased in that I love NK cells. I do not believe that there is a shift necessarily of T to NK. I think at the moment we have to try everything in our armamentarium, really, to try and find therapies that work for patients with those difficult to treat diseases such as solid tumors and AML, where really neither T cells or NK cells have made headway such. I agree with you for hematologic malignancies. There is certainly excitement both with autologous CAR T cells and also with CAR NK cells. And the reason we're very much focusing on the CAR NK cells was because of the concerns, as you very well know, around access, around safety, around affordability. Yes. And I think that we owe that to our patients, to have therapies made available to everyone, not just to a lucky few. And that's why we're pushing forward with a lot of our efforts around that. Having said that, also with CAR T cells, approaches are being taken to bring down the costs. Yeah, with point of care treatment, shortening duration of manufacturing, etc., etc. So I think in a way this is great for our patients in that there are multiple different approaches being tested by multiple different groups. And I think it's too early yet to, the jury's out as to what's the best way.
Right. And it's also the scalability. When you're doing CAR NK, do you think that the scalability of CAR NK is much more better because you are not so much dependent on autologous product? So the scalability will also be much more easier, and you can make batches from just one, let's say donor. So the scalability is going to be much more better.
Yeah, no, you raise a very good point. And as I also presented in my talk, the fact is that we can make more than 100 doses in one donor really does bring down the cost, and it's available sitting in a freezer that we can just store and use, and because they're frozen products, and one could also envisage shipping those frozen cells, right, to be thawed at other centers to patients. So those are all advantages. I think that
and the kind of cure settings, you really don't need, to make those big GMPs in even rural areas. For example, in India, if we have a centralized mechanism or a decentralized mechanism, the cost will always be an add-on. But if you have point of cure centers in, smaller centers, also smaller towns also, these batches could be easily transported to those centers. And it would again bring down the cost because the shipping costs will not be close to the production costs. It's definitely going to be lesser.
Absolutely. And, as physicians and as stem cell transplanters, we are used to cells, be it frozen cells, really shipped around. So that infrastructure is already in place, and we can very easily tap into that. But before we get to that stage, of course, we need more trials, multi-center studies, and innovation and collaboration.
Now, when I was looking at the gene editing strategies, completely a different perspective, I also saw there was more shift of towards talent now and not towards CAR-T. Sorry, not towards CRISPR. So is it because there is a regulatory challenge there, or is it more to do with targeting and efficacy?
So we've been focusing on using CRISPR, and we get excellent knockout efficiency with CRISPR. Of course, there are all the concerns that you have to make sure there is no off-target efficacy, genotoxicity, etc. But we've been working closely with FDA to provide a lot of the necessary and these documentation of safety. We've taken it to the clinic already, as I mentioned to you, for the setting of glioblastoma, and thankfully so far we haven't seen any toxicities with that. Again, it's one of those situations. It's good to have different options. I think some people are shying away from CRISPR, as we heard from one of the speakers, about how do you get access to the technology. The way I look at that is, perhaps let's just try and make it work. And then if it works, we'll find a way.
So there's always innovation, and that's how we also started at Tata Memorial Center. We started with the benchmarks. For example, now we've started with CD19 CAR, and there was a lot of collaboration with international groups, intellectual collaboration with international groups. But then once the path was set up, it was easier, and now we're focusing more on the R&D in-house production at our center. So I agree that, once you have set the path correct and you know the way out, then you can modify it and then you can use it in a better format. So the another thing I was interested in is when you're choosing to produce an allogenic product, let's say for NK. So have you seen any like a better therapeutic outcome in terms of the cell type that you're using for an allogenic product? Like, is there a preference of using iPSCs over let's say cord blood or something like that?
You raise a very, very good question. We haven't done head-to-head comparisons. We are now interested in trying to understand why and what are the differences between, let's say, iPSC NK cells versus cord blood NK cells. I can tell you cord blood NK and peripheral blood NK, in terms of their functionality, ratio expanding, they're very, very similar. We like cord blood because of the fact that we have access to the brain, so it just makes picking the donors very much more convenient. But also you saw what I showed in terms of there's a lot of donor variability with NK cells. So then if you're using peripheral blood, how do you choose your peripheral blood donor?
And as a physician, I could see the dilemma, because you're giving an NK cell product, like say an allogenic product, to see your patients, and then just because one patient has a donor, like one batch has a different donor which is at a better therapeutic outcome or better efficacy, there's another donor which has a different outcome. So the comparison would always be there.
Yeah, and that's of course that's a big problem, right? Because you don't want to have this batch variability. But also, if you're going to be treating 100 patients with one donor, you want to make sure that you pick the right donor, right? Yeah, like this guy. And again, as we refine more of the selection criteria with our donors, hopefully that batch variability will become.
That's exactly as I was trying to make out yesterday, that is there a checklist which we should follow when we are identifying, selecting our donor? So should we add some more points from the data that we already have in terms of efficacy and correlate it with our selection donor checklist and see these are the add-ons which are not a part of our regulatory guidelines or maybe part of the clinical trial, but then let's add that because it kind of improves the efficacy in itself.
Yeah. Yes, I believe so. Now what we are doing is on all of our products, we're doing a single cell multi-omics analysis.
Right.
Really to try and understand, what makes that. And I still think there's a lot that we don't know.
Yeah, so I'm a big fan of using, kind of a combination of proteomics in order to understand the immunometabolism. I feel very strongly that somewhere the T cell, not just the T cell, any cell phenotype, the metabolic fitness of the cell would define how the cell is efficacious, like the drive of the cell, whether it's a killing mechanism or even an oncolytic virus, if it's a killing mechanism or anything. The fitness of an immune cell, if you're using and manipulating I feel immunometabolism has very strongly to do with it.
I agree.
And we should use more of, these multi-omic studies to identify what basically works at basic biology. You yesterday mentioned going to grassroots basic biology would help us identify and solve a lot of problems.
Absolutely. We need to have that basic understanding of the mechanism, and then we can start applying that knowledge for translation and other clinic. I agree.
Thank you so much. And I want to, today is Women's Day, so it couldn't get better than this for me. Thank you so much. It's been an honor. There are so many women scientists who are looking after you, including myself. We've been waiting for this day to come, and we are having you here. And it couldn't get better. We have you on Women's Day. So thank you so much for doing what you're doing and continuing to inspire us. We look forward to having you more and more. And once again, we're full of gratitude for you.
Well, thank you very much. And happy Women's Day to you and to all the beautiful ladies I've met. And I'm so impressed by the women of India. And I can just see that, the field is going to just continue expanding and growing under the leadership of you and the rest.
More power to women all around the world. Thank you. Thank you.
Thank you.